Global Midwifery Research Society conference. And what I'm going to do is to talk about some work we're doing here in collaboration with colleagues across Europe on the primary prevention of congenital anomalies and surveillance towards that goal. And what I'm hoping to do is to put the primary prevention of congenital anomalies firmly on the midwifery research agenda. The sorts of congenital anomalies we're talking about, major congenital anomalies, would occur in more than 2% of births. These are anomalies that are diagnosed prenatally or in the first year of life. And you see a sort of a distribution of the types of anomaly in this pie diagram. In the top right corner is the largest section is the cardiac anomalies. More than a quarter of children born with congenital anomalies would have some sort of cardiac defect. And then you see limb defects, central nervous system, including neural tube defects, oral clefts, chromosomal anomalies, including Down syndrome, urinary genital system defects, and musculoskeletal defects, just to give you a sense of the breadth of what we're talking about here. So my talk is going to go through three areas. First of all, what's meant by primary prevention, then the role of surveillance in primary prevention, and then some brief comments on the role of midwives and midwifery research in surveillance and primary prevention of congenital anomalies. So first of all, what do we mean by primary prevention? Well, we know, of course, this three-tier hierarchy of prevention: primary, secondary, and tertiary prevention, where primary prevention is prevention pre-disease. It's tackling the causes of disease, so that, for example, in relation to congenital anomalies, children who would have been born with congenital anomalies are now born healthy without congenital anomalies by tackling the basic causes of the disease. Secondary prevention is typical of screening programs. It's about detecting early in order to improve outcomes. Neonatal screening programs, for example, for phenylketonuria, have that object. Prenatal screening is in a very odd situation in regard to secondary prevention, in that prenatal screening really falls into two large categories. There's prenatal screening and diagnosis, which improves outcome in the sense, for example, of prenatal diagnosis of a cardiac defect that allows for preparation for birth, preparation for neonatal surgery, etc. And there are many papers now looking at the extent to which that improves outcome for children with cardiac defects. But there's another side of prenatal screening and diagnosis which also allows the mother a choice to terminate her pregnancy, and that doesn't come under the category of secondary prevention as defined here, or prevention. It's not what I'm talking about today, but it is of course relevant to midwifery practice today. And tertiary prevention is surgery and rehabilitation for children with congenital anomalies. So what I'm going to be talking about today is about primary prevention. So how do we build primary prevention strategies for congenital anomalies? Well, first of all, we have to recognize principally that what we're doing is protecting the fetus before the mother knows she is pregnant. The major development of the organs occurs in very early pregnancy, typically before the pregnancy is confirmed. So we can't wait till the mother knows she's pregnant and is accessing services, maternity services, to prevent a congenital anomaly. We have to act before that point, and of course that's a great challenge for midwifery. There are two main groups of action that we need to take. One is pre- and periconceptional care at the individual level, individual care and advice. There are many examples of that. For example, advice to take periconceptional folic acid supplementation starting before conception, checking vaccination status for rubella, care for high-risk women with diabetes or epilepsy so that their medicines, for example, can be changed before pregnancy to lead to better outcomes, genetic counselling for high-risk families who have a family history of a congenital anomaly, and reduction of a range of potential exposures, recreational drugs, alcohol, smoking, etc. That's what we can do with the individual woman. But we can't depend on what we can do with the individual woman, because the individual woman doesn't know she's pregnant at the time that it's relevant, because many pregnancies are unplanned, and because many potentially teratogenic or harmful exposures and not under the control of the individual woman. We don't have a total control over our environment, however much we would like that. So population approaches include, for example, folic acid fortification of staple foods, that if we add folic acid to flour, that reaches the whole population, but including the woman in early pregnancy. Vaccination programs for young children is well accepted and has been done for many years. We include rubella in the MMR vaccine for young children because of the protective status it'll confer later on when the woman becomes pregnant against congenital rubella, and because it'll break the cycle of transmission so that even those who are not immune have a reduced likelihood of meeting the disease during pregnancy. Then there's a whole area of environmental, occupational and pharmaceutical regulations. A woman can't have control over her exposure to air pollution or contaminants in the drinking water. We need to do that at a population level, and that includes protection of the fetus. And what's important is that the fetus is in general more vulnerable than the adult. So we have to know that when we're doing environmental, occupational, pharmaceutical, etc. regulation, that protecting adult members of the population is not enough. We have to always be thinking that the fetus is there needing additional protection at a particularly vulnerable time of the development of the organs. And then all strategies to tackle the major health determinants, smoking, alcohol, obesity, etc., need a chapter that's looking at how does this affect women in early pregnancy in the periconceptional period. Okay, so moving on to the role of surveillance then. Epidemiology, the study of the distribution of health and disease in the population. It's a population approach in relation to the determinants of health and disease. By extension, epidemiologic surveillance is the continuous scrutiny of the distribution of disease in a population in order to take and evaluate control measures. So it's very applied to, in this case, primary prevention. But in its nature, epidemiologic surveillance is taking routine data. It's taking data that's generated in ordinary health service practice. This is not specially collected research data. It's the data that's generated by midwives, clinicians, of all sorts. And then making the best use of that in order to feed back into the primary prevention cycle. And we can see that in terms of 4 levels. First of all, epidemiologic surveillance is needed for identification and measurement of the problem. How much congenital anomaly is there in the population? What are the risk factors? How prevalent are the risk factors? On the basis of that, evaluation of potential interventions. How can we reduce those risk factors in order to reduce the problem of congenital anomalies? Then implementation of primary prevention actions, and then monitoring success of those interventions. And rather reminiscent of what Michael Robson was saying this morning about monitoring the success of active management of labour, whatever you do based on the evidence, of course you want to monitor at the end of the day that that actually did work, because in the end an implementation, an intervention is a complex intervention. It's not based just on whether you're interested in folic acid or oxytocin or a single factor. An intervention is almost always complex, and you're not quite sure how it's going to work. In the end, you need to monitor the impact and see whether it did what it was intended to do. And epidemiologic surveillance would be involved particularly in the first and the last of those levels of primary prevention. So in Europe, we have EUROCAT, European Surveillance of Congenital Anomalies. This is funded by the European Union DG Sanco Public Health Programme, and we're here at WHO Collaborating Centre for the Epidemiologic Surveillance of Congenital Anomalies. EUROCAT is a European network of population-based registries for the epidemiologic surveillance of congenital anomalies. A population-based registry meaning essentially that in a geographically defined population, whether that's the nation or a region in the country, all children born with a congenital anomaly and including also all terminations of pregnancy following prenatal diagnosis are registered. A standard data set is recorded in the registry on those children. So it's all children of mothers resident in that defined area. The network was started in 1979. It was quite small then, but it now covers 28% of all births in the European Union, which is about 1.5 million births per year, in 39 registries in 22 countries. And we have a very comprehensive website if you want to look at the information that's produced. So here's a map of where all the registries are across Europe, and you see in the top left corner the central registry here in Belfast at the University of Ulster in this building upstairs. And basically what we have as a tool for surveillance is a central database which collects standard data on anonymized individual cases of congenital anomaly from across Europe. We have more than 400,000 cases documented since 1980, including, as I've said, live births, stillbirths, and terminations of pregnancy. What's the scope of EuroCat activities? Well, the objectives, I think, are in the abstract in your pack, but it's more easily presented, really, according to the 3 Ps: prevalence, primary prevention, and prenatal screening and diagnosis. So we have actions in all those 3 P areas, but I'm only talking about primary prevention today. And primary prevention, the whole rationale for having registers back in the late 70s and early 80s when EuroCat was started, really started with thalidomide. The rationale was we can't let thalidomide become such an extraordinary large-scale event again. We need surveillance and early detection of any problems, for example, due to new medicines on the market. But nowadays we have a large scope even within the sort of primary prevention scope, including response to exposures of unknown teratogenicity. Chernobyl was a good example in the past. Swine flu vaccination now is one of our ongoing studies, is to look whether swine flu vaccination in early pregnancy has had any effect on the babies born afterwards. And I'll go through some other examples in more detail. So the first example is around neural tube defect prevention by folic acid, well known to all midwives. You know that in the 70s and 80s, observational epidemiologic studies established that insufficient folate was a likely cause of neural tube defects. In 1991, a large randomized trial, established the protective potential of folic acid supplementation. So in a sense, it was felt now we have absolute proof. It's not just a likely cause, it is a cause. We could, it was estimated, prevent 2/3 of neural tube defects through periconceptional folic acid supplementation starting before conception. So in the 1990s, following the publication of that trial, governments around Europe developed policies regarding folic acid supplementation and health campaigns to reach women regarding the need to start supplementation if they were planning a pregnancy. So has all this been successful? We have, in this case, a primary prevention tool. Have we been able to implement the primary prevention measure, the health education campaigns, successfully? Well, our surveillance data allows us to produce these data. I'll explain to you, this is the total prevalence of neural tube defects. That includes then live births, stillbirths, and terminations of pregnancy. So if you like, it's corrected for prenatal screening. The total prevalence per 10,000 births. And the top line is the UK and Ireland, which have traditionally been high prevalence areas for neural tube defects. And the bottom line is the rest of Europe that you saw on the map of the EuroCat registries. And this graph goes from 1980 to 2004. And you see on the top line, of course, don't worry about the vertical bars, they're the confidence intervals, and they just tell you that it's a big study and this is not chance fluctuation. The decline is huge in the 1980s of neural tube defect prevalence. And in fact, that's a continuing decline. There is data available in different areas of the UK